All right, so now I'm hoping that Dr. Emanuel Rivers can get us back on track. Dr. Rivers is Vice Chair and Director of Research and Emergency Medicine at Henry Ford Hospital in Detroit. He was an extraordinarily important individual in identifying the importance of early goal-directed therapy in septic and helping us to understand the impact of septic shock. So, Dr. Rivers, please rescue me from myself.
Thank you so much for that warm introduction, and as well as being able to follow such wonderful speakers. You make it hard on me, but I'll do the best I can.
Thank you.
I have no competing interests. Next slide. And I want to thank the National Academies, as well as the Gordon and Betty Moore Foundation, as well as the Planning Committee. So the early pathogenesis of sepsis begins with an infectious insult, which stimulates a generalized inflammatory response, which subsequently leads to what we call microvascular alterations, which have a great impact on tissue oxygen utilization. Now, this progresses to a disease that creates both what we call a inflammatory phenotype as well as a hemodynamic phenotype, because the infectious insult can alter the supply and demand relationship between oxygen supply and demand, and subsequently progress to develop organ dysfunction. As you progress in this cascade, there's a hemodynamic phenotype that starts to begin. One of those phenotypes include heart rate, blood pressure, and also evidence of impaired oxygen utilization, such as lactate and venous oxygen saturation, which subsequently can develop and create what we call an inflammatory response, which can exacerbate the whole cascade as it once begins. So when a clinician sees a septic patient, depending on location, either one of these issues may predominate and thus lead to the clinical interpretation. So when we look at sepsis as a phenotype, we can look at it as a disease with a commonality of hemodynamic, what we call variables. So if you look at lactate, blood pressure, and you look at venous oxygen saturation, that phenotype can be totally changed by a mixture of these, what we call hemodynamic variables. And as you can see, based on the phenotypic presentation from a hemodynamic perspective, the mortality of sepsis can be significantly variant based on location of the patient. So when we look at sepsis definitions, they are very important, but more importantly, they're a clinical communication between clinicians. More so than reflecting the underlying pathogenesis, they give us landmarks in terms of how we define a patient, both from a prognostic and therapeutic perspective at the various locations of presentations. So there's both the hemodynamic and inflammatory phenotypes that provide a source of heterogeneity in sepsis interpretation. So as an emergency physician and critical care physician, in the early 90s, I was able to see a disease that perhaps was uncharacterized in the early settings. Because when you look at a lot of studies and you look at the current way we've progressed in terms of sepsis care, it reflects a systems issue. In the 1990s, the Institute of Medicine published 2 reports that discuss the frailties of emergency care and also the stress that emergency medicine was seeing throughout hospitals in the U.S. And this was actually acknowledged even within the last year, with this article by Singer et al. Actually examined emergency medicine as well as emergency department visits, and saw that in the last decade, they've increased significantly every year to a total of 145 million visits, which sepsis actually comprises about 1.7, almost exactly the number of patients described by a previous speaker. So when you look at the sepsis landscape, and let's go back to 1997 and see what the landscape of sepsis was, it was just like this beautiful evening in the mountains. There was no what we call standard operating procedures for sepsis care, early sepsis care. So when you look at sepsis as it evolved as a disease, it originated from an ICU perspective. And then subsequently, we realized that these patients come from somewhere. They come from the floors. Then if you further look at where septic patients come from, 50% come from the emergency department. And so when you expand that landscape, you can see that sepsis care diagnosis actually changed based on the location of the patient. So take a fast foot forward, and you see this article by the Surviving Sepsis Campaign that basically showed internationally we see the same phenomenon, whether in Europe or the U.S. The emergency department sepsis mortality is significantly different from a ward patient versus a patient who is primarily sepsis in an intensive care unit. So sepsis by location has a significant phenotype as well. So look at this landscape and how it's changed, because from 1999, there was a consensus statement by the Surviving Sepsis Campaign and as well as the Society of Critical Care Medicine Expert Task Force, but this did not apply to early sepsis care. So when you look at early sepsis in the 1990s, there was no surge criteria. There was no risk stratification, no use of lactate, no antibiotic recommendations, including resuscitation. So no fluid requirements, blood pressure, as well as the recognition of underlying hemodynamic perturbations. And more importantly, if you look at quality assurance measures, Surviving Sepsis Campaign, and even CMS measure, those were not in existence in the 1990s. So that gives you some idea of how far we've come and perhaps how far we need to go. So let's look at some fellow diseases and see what the relationship and management principles were at that time. You take a stroke patient, mortality 6 to 7%, but we had guidelines for stroke care. Acute myocardial infarction underwent very similar transitions in care, where we have now guidelines for the acute myocardial infarction. And trauma, that golden hour, which has really never scientifically been proven, is pretty much a standard of practice throughout trauma units throughout the country, again, with mortalities less than 16%. But then you look at sepsis, and whether it's severe sepsis or septic shock and even pneumonia, many people don't realize that pneumonia is a form of sepsis, and these comprise millions of patients with mortalities that's totally unacceptable in other diseases. So this is kind of the landscape of the early 90s. So let's take a step forward and say Dr. Peter Saffer, who basically said that critical care is not a location and a process that should take place outside the critical care unit. So a thought and perhaps a what we call paradigm shifted at that point in time. So we decided to take the Surviving Sepsis Campaign and Society of Critical Care Medicine recommendations in the early 90s for a septic patient in an ICU, and that was to give a patient fluids, inotropes, get that lactate, check that venous oxygen saturation, and perhaps transfuse that patient if anemic. Those were done in a standard ICU care for a septic patient. But take a step forward and say, well, let's apply it to the most proximal phase of emergency department arrival. And that gave what we call the concept of early goal-directed therapy. And since that time, this concept has been transitioned into what we call a system change in sepsis care, where we now have steps in terms of early recognition. We also have a label of sepsis, and many don't realize that the word SIRS is not necessarily a pathogenic characterization. It is a language that allows clinicians to use the same terminology. So if you say SIRS, most people think infection. And when you use that terminology, you allow yourselves to have better communication across specialties. There's also the risk stratification piece of lactate, which also provides what to do with that patient. When you have a patient with chest pain and you want to rule out an MI, you order a troponin. So that's a risk stratification more so than a pathogenic transition. And then the cultures, the antibiotics and source controls, which provide the framework of a sepsis alert, early recognition of those patients who are at what we call a cryptic shock transition, which comprise up to 20% of your septic patients. And then the hemodynamic optimization piece, including a quality assurance mechanism so that we can observe and perhaps measure our outcomes. So when you look at the landscape of sepsis, there was a what we call transition in terms of clinical care, but also a policy transition. And if you look at the year 2003, the Surviving Sepsis campaign came up with the first guidelines. There was a Sepsis Alliance by Dr. Flatley, followed by, again, the first sepsis measure sent to NQF in 2008, and subsequently followed by another Surviving Sepsis campaign examination. And then the New York State became the first state in the U.S. to actually establish statewide protocols for sepsis care. And subsequently, other states became involved. Process, Arise, and Promise trials basically influenced the baseline care of septic patients, and they were taken in consideration by CMS, which basically provided the first national sepsis measure, and then the Center for Disease Control in 2016 recognized sepsis as a major acute disease, and subsequently the care of sepsis landscape has significantly changed. So when you look at it, of course, of the last 2 decades, we've seen a significant reduction in sepsis mortality. Again, the concept of early sepsis care began in 2001, and there were 3 major trials, Process, Arise, and Promise, which influenced what we call the process of managing sepsis in terms of hemodynamic optimization. But what these trials did in combination is basically elevate, improve usual standard care, which includes a step of variables that comprise the baseline care that we should all give a septic patient. So when you look at the outcome evidence, 2 major studies done was the New York Hospital Association, which basically provided the early sepsis bundle, over 50,000 patients looking at time to various sepsis components. And this actually showed a mortality reduction of over 5% and relative risk reduction of over 20%, in addition to a decrease in hospital length of stay. So the first statewide public policy to show sepsis outcomes improvements. More importantly about this study was that it showed that it's a bundle phenomenon. And even though there are individual bundle elements that have shown mortality reduction all the way from lactate, blood cultures, antibiotics, in addition to vasopressor use, the combination of these variables were stronger than either one alone, which basically says the bundle is much stronger than an individual element. The key point is there's still a lot of work to do. The recent study by Dr. Timothy Buckman published in Critical Care, and this was over 1 million Medicare patients, basically showed that we've made great strides. Whether you look at 1 week hospital stay, you look at patients after 6 months, 1 year, and even up to 3 years, mortality reduction from sepsis, septic shock has significantly been diminished over the last decade. But it's important that even today, septic shock mortality for a Medicaid patient population, 35 to 38%, and severe sepsis, 25 to 30%, which is much higher than what we've realized and quoted in other studies. So one of the, I think, things that we've forgotten about in the recent time is the use of immunotherapy. Again, activated protein C was mentioned in 2001. Now was considered a standard of care in sepsis management. However, it's gone by the wayside. I think with early diagnostics, one example of perhaps the reuse of what we call immunotherapy comes from this study by Dr. Opel, who we'll hear from in shortly, basically with the use of IL-1 receptor antagonists. The fact that we can look at early diagnostics in this case may change the conclusion of this study, which actually showed no outcome benefit. But again, this was in a patient population that was enrolled within 72 hours of sepsis diagnosis, within 24 hours after the clinical onset of infection. This may be what we call lifetime for a lot of patients, because when you look at the magical time period where we should enroll these patients, it actually may be in earlier phases of the disease. So we took one step from the early goal-directed therapy study and was able to analyze the natural history of certain inflammatory mediators, and one specifically was IL-1 receptor antagonists. And we examined these patients from hospital arrival every 12 hours until 72 hours into their hospital stay. And what's interesting about IL-1 receptor antagonists, its biomarker activity is greatest during the first 3 hours of hospitalization. So in most hospitals, if you come through the ED, you pretty much have spent this time even in triage or perhaps prior to even being seen by a clinician. And then once a diagnosis is made and the patient sits in the ER for 24 hours, you can just imagine that enrollment in a clinical trial in general using that time period is too late. And in this study, the 72-hour infusion actually began 24 hours after diagnosis, which is pretty much far removed from the peak activity of the disease presentation, which gives rise to the fact that this session of biomarker activity and biomarker diagnostics, I think, holds great promise in sepsis care. And irrespective of the clinical change in management, I think that there is still a room for the use of biomarker diagnostics and further use of immunotherapy. So I want to conclude by saying that the importance of early diagnosis and clinical care in sepsis is a chain of survival. Early detection and risk stratification is a key piece in early sepsis care. In addition, appropriate disposition. Where do you put these people so they don't have the sudden deterioration that we've seen in the past? And in addition, early and rapid hemodynamic as well as inflammatory phenotypes, because these hold great promise in both diagnostic and therapeutic interventions. And lastly, we have to have a quality mechanism in order to examine our care so that we can take great advantage of the resources we have to improve our outcomes.